Woo. Hey guys, welcome to my channel. I hope you all are doing okay. Today I would like to continue, but then this time around the next few videos will be about the brain and the spinal cord. There's a lot going into them, so for this video I'm going to focus on increased intracranial pressure of the brain. Okay, so just let's know like basic like anatomy of the brain. The brain has parts, like it has the frontal area, which helps with decision making, you know, like kind of like setting your mind onto something. And then you have the parietal, which helps you with like spatial orientation and things like that. Then you have the temporal, which helps with like language, understanding, long-term memory. Then you've got the occipital, which is the back, which helps with vision. Then you've got like certain areas in the brain somewhere down here, which is the brainstem. And the brainstem is very important because it regulates like body temperature, like your breathing, and what else, possibly your blood pressure if I'm not wrong. And I would just like to show you how cute my thing looks. So I have this whole chart that I did to help me out. Okay, like my brain is not picking shit at, excuse my language, my brain is not picking things as fast as they used to. I used to just get stuff, but anyway, we'll manage what we have, you know. That's what I learned this year. Just do with what you have. So increase intracranial pressure. So increase intracranial pressure then is just pressure in your brain, and this could be due to having a tumor in the brain. This could be due to having a bleed in the brain, like you know, you had trauma and you're bleeding. It could be due to over secretion of cerebrospinal fluid into the brain. It could be due to edema, like brain swelling. So anything that increases pressure, like an infection, an infection, CO2, increased CO2, which will cause vasodilation of your vessels, therefore increasing blood pressure. And yeah, so that's what that is. And a normal normal intracranial pressure is between 5 millimeters of mercury to 15. So when you get to like 15, it's kind of like, you know, high, on the high end. So really 5 to 10. So yeah, that's what that is. And the reason I mention all this part is that sometimes if there's a lot of pressure like in the front, you might see a problem with like, you know, personality or decision, or if there's pressure on the sides, you know, understanding long-term memory loss, you know, things like that, which we'll go into in the next video. Okay, what are early signs of increased intracranial pressure? Like I mentioned, you might have like hallucination, something called delirium, like you might be delirious, like sudden change and like, you know, you don't know where you are, you're just saying things that don't make sense, you know, that type of thing. Or you might have like a headache, sudden headache, you know, muscle weakness, or like confusion. So that is early sign. But then the late signs then would be vasomotor problems, let's say vasodilation causing increased intracranial pressure, brainstem, a problem with the brainstem which might cause bradypnea or low respiration, fixed pupils, projectile vomiting, like just vomiting without nausea, especially in the morning, or really, really bad is something called decorticate or decerebrate. Decorticate is when your hands are towards your body and it is flexed and your legs are extended, whereas decerebrate, your hands are extended, and your legs are also extended. That's the worst case scenario. Okay, and then to measure when it's really bad, you know, towards the coma, we're gonna use a Glasgow Coma Scale, which measures like level of consciousness between, on a scale of 0 to 15, 15 being the best, like 8 being like bad already. And the levels of levels of consciousness is a coma, where you're just like knocked out, you know, but your brain is still there. And then you have akinetic, where you're not moving, but you know, you might still be awake. Then persistent vegetative state, where you have this sleep wake cycle. I don't know what that means, but I just memorized. And a locked-in syndrome usually has to do with something called ALS that we'll talk about in the next video, where you're aware, your eyes are open, but you can't move, you can't say nothing, things like that. Okay, now that we've talked about the early signs of increased intracranial pressure and the late signs, we're going to then move on to, we already talked about the cause. Some of the complications are fluids and electrolyte imbalance. So with increased intracranial pressure, it can press down on your pituitary, which might cause a problem with now I'm trying to think, pituitary, is that ACTH? Now I gotta look that up. But yeah, it can press on certain areas in your brain that helps with regulating certain hormones, as in like cortisol and things like that, or the pituitary with that, and the hypothalamus with SIADH. I gotta check that out. SIADH and DI. So SIADH will be water retention, because syndrome of inappropriate antidiuretic hormone. This hormone helps retain fluids, so your body is going to be retaining fluids, you know, because the tumor or whatever is pressing onto that part of the brain. Like I said, I don't know if it's the pituitary or the hypothalamus. I will double check that. Or you could have DI, where that same area of the brain, diuretic is kind of like diuresing. With this, you're gonna check it with urine specific gravity, where for DI it will be very low, for SIADH it will be very high, you know, like 1010 to 1020, you know. Yep. So then if it's SIADH, we put the patient on fluid restrictions, sodium restriction. We're gonna still monitor ABGs due to the you know, we might have hemo or pseudo hyponatremia, which might affect level of consciousness again. And things are kind of put with each other, so it's hard to differentiate. Things are connected. So with increased intracranial pressure, there might be build-up fluids causing cerebral edema. This is an emergency. With this, you might see something called a Cushing's triad, where we'll see bradypnea, bradycardia, and hypertension, as in your breathing will be low, you're going to have high blood pressure, and your pulse is going to be very low too. It's an emergency. Also herniation of the brainstem, which might cause low respiration and possibly coma, because your brainstem is really important in regulating blood pressure and all that. It might be related to you having a Cushing's triad. Also with this, it is important to check CPP, which should be greater than 50. Good is 70 to 100, but if it's less than 50, that means your brain is not receiving enough oxygen, and your brain kind of loves oxygen and sugar. Let me have some sugar. Let's stand up. Your brain loves oxygen and sugar, so kind of like your car and gasoline. So if you're not able to have oxygen to the brain, your CPP will go low due to vasoconstriction happening in the brain, as in a compensation factor to to compensate for either high CSF or cerebrospinal fluid or increased blood in the brain. Okay, so we talked about the relationship between fluid and electrolytes and SIADH. We talked about cerebral edema. We talked about Cushing's triad. We talked about herniation. they're all connected. So then some of the treatments we can do are like surgery. So we can do a craniotomy or burr holes. A craniotomy kind of just helps decrease pressure, like it's like emergency. They'll literally cut your brain open to decrease pressure. So yeah, to evacuate a hematoma, to just release pressure from the brain, or remove a tumor. Yeah, relief ICP from a tumor, from a hematoma. From hematoma is pretty much like a big bleed like in the brain. Or we can do burr holes, which will give access to the ventricles in the brain, where we can kind of monitor intracranial pressure after some sort of like surgery or anything like that. So it will check for swelling in the brain, and we can kind of evacuate like a brain abscess and do a bone flap. And I have no idea what a bone flap is. I memorized that one. Okay. So with these surgeries, then we want to watch out for seizures. Obviously, any irritation to the brain will cause seizures. It will cause pain, so seizure and pain. So we want to really give pain medications and probably some anticonvulsants. And I gotta look up meds for anticonvulsants because I can't remember them right now. I think carbamazepine could be one, or what's another one? It starts with a V. Vial. Oh my god, I can't think of it. But yeah, basically with those you want to watch out for all I can think of is like bleeding or blood dyscrasias. That's all I can think of, or toxicity to the liver and the kidney possibly. That's all I can think of. And so yeah, so after these surgeries, or let's say your patient has this increased intracranial pressure, or we suspect it, so the first thing a nurse needs to do, I think I kind of skipped a little bit. So I talked about the burr holes, I talked about craniotomy, and I talked about the complications of them. So some other treatments that we might do is the use of mannitol. It's an osmotic diuretic. It kind of pulls fluids from the the surrounding areas of the brain to the vascular areas of the brain. With this, we want to watch out for fluid overload in the body, because it's kind of like taking fluids and then just dumping down. So we want to watch out for pulmonary edema and just edema all over the body below the head. Then we can give corticosteroids if the patient happen to have like a tumor, and with this corticosteroid, is good and it's really bad. It will help decrease inflammation, but then we want to watch out for, again, altered level of consciousness itself. We want to watch out for infections. We want to watch out for bleeding, which is still might be bad for the brain. We want to watch out for hypokalemia, hypernatremia, as in high potassium levels, low sodium levels in the body, muscle weakness. Yeah, I think I covered everything. So like infection, bleeding, altered level of consciousness, hypokalemia, low potassium, high sodium levels. Okay, so those are the treatments. And then with the craniotomy or the burr holes, we can do sort of like do a ventriculostomy, where you kind of put a device into that area to measure intracranial pressure. And there is also something called the foramen. We put it to the foramen of the Monroe, where the patient will lay flat, okay, and we'll put it like 2 to 3 inches above the ear. That's all I remember. Is it 2 inch? 1 inch above the ear, 2 to 3 centimeters. Okay, so that is that. And if the patient has these surgeries, there's still a risk of increased intracranial pressure. So you want to prevent further increase in intracranial pressure. So you're gonna have them sit like straight up, aligned. Stop them from coughing, from increased like coughing, bearing down, like with constipation. You want to avoid that. And with surgeries, we give medications that like opioids, which might cause constipation.
Charlie, I found disconnected.
Oh, which might cause constipation and respiratory depression. So we really want to watch that. And I gotta find out if it actually is contraindicated, like opioids. Yeah, so we want to give like high fiber foods to prevent straining and to prevent coughing. Tell the patient not to, do this because it increases pressure, or go down like that, it increases pressure. And we want to really avoid stimulating the patient, as in turn on the light, just ask way too many questions. We want to allow the patient to rest. And avoiding enemas too. We will give stool softeners instead of enemas. You want to ask the patient to breathe out before turning, like it decreases pressure in the abdomen. Yeah, what else? I think that is it. Alright guys, so that is it for the video. It might have been a little bit all over the place, but try to understand that it's kind of difficult because increased intracranial pressure is, everything is kind of like intertwined. It's like, okay, the complication is cerebral edema, which could be caused by just water retention from something else, or trauma, or just inflammation, or it could be caused by pressure to the, I don't know if it's the pituitary or the hypothalamus. I gotta go and check. So it's kind of like everything is intertwined. But I hope you found this helpful. Anybody who is interested in this kind of stuff, I know it's kind of dry cut, but if you liked it, please like the video. Thanks for watching my video, and I'm gonna peace out to the next one.